So good evening, everyone, and thank you for joining us in the first of our series of CPD 2022 webinars from OCL Vision. My name is Purvi Thompson, one of the optometrists who works at OCL Vision. Thank you to everyone who's joined us today, those of you who are joining us for the first time, and those of you regular viewers who watch us every time we host a webinar. So things are a little bit different, as you know. CET has changed to CPD now, so I won't be uploading points directly to your GOC account. Instead, what you'll get from me is a certificate to say that you attended and viewed this CPD. So please, when you do register to join our events, use your correct name as per the GOC and the correct GOC number, as that is what will be entered on your certificate and it cannot be changed. So for those of you that are regular viewers, you'll know what I'm about to say next. A small bit of housekeeping. All these webinars are recorded and will be available to watch on our YouTube channel, OCL Vision, in about 20 days or so. There is one interactive CPD point available for this webinar, and that will be for optometrists, contact lens opticians, dispensing opticians, and therapeutic prescribers as well. The lecture will run for about 45 minutes with questions at the end. So if you do have any questions, please enter them into the Q&A box throughout the lecture. This lecture is a little bit interactive, so at points Laura will be asking you for your information and some chat. If she asks any questions, please enter them in the chat function, but any questions that you have for her, please enter in the Q&A box. I hope that makes sense. So today's speaker is Laura de Benito. Laura is a consultant ophthalmic surgeon with us at OCL Vision and also at Moorfields Eye Hospital. She's a specialist in corneal transplants, cataract surgery, lens and laser surgery. Laura, I'm really excited to have you on board for your first OCL webinar. Good luck and over to you.
Thank you, Purvi. Thank you for the introduction. So let me share my screen now and we can get started. Good. Can you all see it? Can you see it, Purvi, well?
Yeah, absolutely perfect. Thanks, Laura.
Perfect, thank you. So today we're going to be talking about red eyes, the differential diagnosis, and what is just a minor problem that the patient doesn't need to see anybody else for, or whether it's something urgent that you need to advise the patient to go straight to A&E. Purvi has already explained where I work. I'm based for my NHS at Moorfields. I do a bit of private there, and my private mainly is at OCL Vision here in New Cavendish Street. So let's get started, and this is where I would like you to join me, because otherwise I find the webinars are a bit only one-sided and a bit boring maybe for you on your side. I think if I'm going to ask you sometimes to think a bit so I keep you engaged. I'm happy for you to write in the chat so I can hopefully see your answers here. Perfect, yes, I can see some answers. So, and if throughout the talk, to make sure that you're following me, I'll be asking you questions and making you think a bit to make this a bit more fun. So, a patient comes to your practice and they complain of red eye, and the first thing you need to ask them, the first thing you need to do, the first thing you're going to do is what? Can you write some ideas there? Wow, lots of questions, really good answers actually. Lots of really good answers. So I saw one of the first ones to answer answered the right thing. Let me see if I can, yeah, exactly. Symptoms and proper history. So many people have answered how long. So basically, you need to make a proper history, and how long is included in that history. Some of you have answered about contact lenses, perfectly fine. So the main thing is the symptoms of the patient and the proper history, even before you see the patient on the slit lamp, even before you take their vision, because just the history and the symptoms are going to give you more than half the diagnosis, and then you'll already be in your mind knowing, oh, this I think is going to be this, I think is going to be that, and when you see them on the slit lamp, you'll be looking for those things to confirm your diagnosis. So really well done. I'm glad that we're able to let me try and move this chat. Good. So next thing is going to be I thought of giving you some practical points that I find when I see a patient and they complain of red eye, I ask them 3 questions. I find 3 questions are extremely useful. And many of you have answered that in the chat. Is it painful, or what type of discomfort they have? Do you have discharge? And is there loss of vision? And with those 3 questions, depending on their answer, you're going to go down this differential diagnosis tree. But do not get worried about this tree just yet, because we're going to go one by one. It was very useful to see in some of your answers, they mentioned to contact lenses, they mentioned whether it was taking very long to heal or how long had been going on. I think there's a few things that really need to warn you, to make you worry when the patient mentions them, that it may be something severe that may need to be sent to A&E. And I put them in here. You've mentioned, some of you have mentioned contact lens. Contact lenses can cause significant infections, so those needs to make you worry about it. Visual loss, if there's significant pain, if there's a purulent discharge, will make you think of an infection. If it lasts too long, if there's a recent trauma or surgery, or if there's corneal haziness, corneal infiltrator, hypopion. So all those things need to be kind of bringing warnings to your mind. But we're going to go one by one down this differential tree. So first one, more on the left. If the patient answers to the 3 questions that they do not have discharge, that do not have pain or significant pain, that there's no discharge, there's no visual loss, and probably there will be just some focal redness. The pain may be there, or maybe just mild discomfort, but it's not the main thing. And you've got all these pictures here. Before I give you the diagnosis, would you have a go at the chat and try and tell me, for example, the possible diagnosis of this first top one? What do you think it may be? There's a minor nodule there. Well, you got it right. Good. So the first one is epioscleritis. The epioscleritis is this focal redness, a bit of discomfort, but not very significant pain. And many times it just goes on its own. So the only thing you need to tell the patient is just reassure the patient. They can have some ibuprofen over-the-counter tablets that usually resolves the epioscleritis. And they do not need to be sent to A&E. Usually, if it's the first episode, it goes away in a couple of days, that nothing else needs to be done. However, if they keep recurrent episodes, they will need a routine referral to get some blood tests done, just to rule out any systemic causes. The second picture, well done. So conjunctival hemorrhage. And as you know, that's not doesn't affect the vision, doesn't affect the eye. You need to reassure the patient. If anything, send the patient to get their blood pressure checked. If they are on tablets, sometimes it's a peak of high pressure that made the vessel burst. Following picture, this one down left, pinguiculitis, well done. So pinguicula usually doesn't need any treatment. Advise the patient to avoid any irritation, so use lubricating drops, use sunglasses when it's sunny or windy, and avoid any eye rubbing. Usually pinguiculas don't get treated in the NHS because it's not within the scope of doing surgery for the NHS, but it can be treated privately if it's bothering the patient a lot. And then the last one, pterygium, well done. I see you already there joining. I'm so excited. It's so much more fun. So the pterygium, as you know, if it grows over the cornea, then it can affect the vision. At the beginning, it will cause some astigmatism, so if you notice that the astigmatism of the patient in their glasses have changed, it may be a sign that the pterygium is growing, and then they need a referral to get that sorted at the hospital. Next one, we're going to go to the second part of the differential tree. When you ask, is it painful? And they say, well, it's not really painful, but it stings a lot. It's really burning. And the vision, and this is very typical, the vision fluctuates. It's not the same throughout the day. And it usually gets worse after long hours on the computer or at the end of the day. What do you think it is? Well done. Blepharitis and dry eyes. These are easy. Well done. You're doing really well. So blepharitis and dry eyes. We're not going to go too much into the simple ones because otherwise this talk will last forever. But I did want to mention the blepharitis that is really a severe one that we need to see at the hospital. So a cornea specialist needs to see at the hospital, which is the one that affects not only the lids, but also the cornea and the conjunctiva. And this is the ocular rosacea. So ocular rosacea usually happens with skin rosacea. So you'll see the patient come in with these blushed cheeks. They tend to get blushed very easily at the changes of temperature with some foods. They tend to get this nose, which is quite red with a lot of little vessels. And when they become older, they develop these tuberous changes in the nose, which is called rhinophima, which is very typical. So in these cases, the blepharitis becomes a proper ocular surface disease, and it can cause vascularization, as you can see here. It can cause corneal infiltrates, it can cause scarring, and it can cause significant loss of vision, sometimes even corneal perforations. So if you see a patient with a normal blepharitis, you know what to do. You advise them hot compresses, lid hygiene, explain how to do the proper lid hygiene. So if it's only outside the eyelids, it's not enough. They really need to reach for the glands. However, if it's this one, on top of the massage and the lid hygiene, these are the things I will be doing. We'll be giving them some tetracycline, so either doxycycline or limecycline. I really like limecycline because it's much better tolerated in the tummy. It doesn't give them nausea. It really improves also their skin. Sometimes we use topical azithromycin. Many of them will need topical steroids and long-term cyclosporine A, which is the drop called Icurvis. And sometimes this is not available in the NHS, but privately, and it works really well. Treatments with Blefex to clean the eyelids properly, and IPL treatment for the glands can be very useful. We're advancing well. Next one. So to the 3 questions, remember, is it painful? Does it have discharge? Is there loss of vision? We're going to go with the significant discharge as their main complaint, and then you're going to ask, what type of discharge is it? Is it purulent? So is it green, yellowish? Is it like dirty? Or is it just mucus, like a transparent, more mucus like filaments? So if the answer is this, like dirty discharge, like sticky, yellowish, greenish, what are you going to think it is? Well done. I'm looking at the chats. See your answers. Well done. Okay, quite a lot of answers there. I'm glad to see that you basically think it's infectious. Many of you have answered bacterial conjunctivitis. And it's partly true, but that would leave out quite a few cases, quite a few diagnoses where there is discharge too, but it's not just a bacterial conjunctivitis. It can be a viral conjunctivitis, which is not a bacteria, and it can be not a conjunctivitis, but a keratitis. So we've got both situations. If it is, if the cornea is fine and it's just mainly the conjunctiva that's red and it's a lot of sticky discharge, but the vision is usually still fine, there's exceptions, then it's usually a conjunctivitis, and we're going to see later in the next slides which ones are viral, which ones are bacterial, and then there could be pain and there could be some loss of vision, and when you look at the patient, there's an infiltrate in the cornea, and obviously if there's hypopion too, then it's a keratitis, an infectious keratitis. So both situations, even the infectious keratitis, are also going to have some discharge. I'm actually surprised sometimes when I teach my junior doctors and the fellows that they look at an infiltrate in the cornea and they don't know whether it's infectious or it's inflammatory, and sometimes they don't ask the most common, like the most obvious question: is it sticky? If the eye is sticky with green yellowish discharge, it's probably going to be infectious. Whereas an inflammatory infiltrate in the cornea won't have discharge, a sticky discharge in the eye. So sticky discharge means possibility of infection, where it is just conjunctiva, where it's just cornea, whether it's cornea 2, whether it's viral or bacterial, that'd be different. But you need to think of an infection. And I really like that you've answered there, thinking of that. So let's go through some differences between one and the other. So viral conjunctivitis, you're going to see these features in the eye. You're going to see follicles. This, as you know, usually quite significant. You can see this subconjunctival petechia, so little hemorrhages, little dots of hemorrhage in between the follicles. And in some more severe cases, you can see the pseudomembranes, which are these deposits of the inflammatory tissue that builds up in the conjunctiva. And if you peel it with a cotton swab or a spear, you will see the very red conjunctiva underneath. If you have very severe pseudomembranes, it means that that's a severe, usually adenoviral conjunctivitis, and in those cases they need to go to A&E because we will need to clean those membranes regularly to avoid the development of scarring afterwards. If it's a mild one, then the main thing is to avoid infecting others. So it's extremely contagious. You need to advise them strict hand washing and not to share any towels. If they can, it's better to clean their hands with, to dry their hands after washing with kitchen paper. They should not share pillows. They should not kiss their family much. They cannot go to work or school until the eye discharge ceases. And you, in your practice, need to see the patient with gloves, or at least you need to wash your hands really well and clean all your instruments afterwards, so the slit lamp. And you need to warn them that even if they use antibiotics, because they can buy chloramphenicol over the counter, that will just be either if it's bacterial, because sometimes at the beginning of a viral conjunctivitis, you don't really know whether it's viral or not when it's early. So if it's bacterial, it'll respond to the antibiotics, but if it's viral, it's not going to respond. So it will need a couple of weeks for the eye to get rid of the virus by itself. The chloramphenicol is still useful anyway to avoid a superinfection. As you know, some of these adenoviral cases, they will develop later on. Once the conjunctiva is healed, they can develop these these kind of dots of infiltrate in the cornea, and those will need to be seen by an ophthalmologist because they'll need steroids, and they're usually quite recurrent. It's difficult to get rid of. So the very severe ones, remember, send them to A&E so that we can clean the pseudomembranes and give them some steroids. A bacterial conjunctivitis. So a bacterial conjunctivitis will also be red eye and discharge. Usually the discharge is a bit less usually than in a viral conjunctivitis, but many times, as I've said, it's difficult to tell whether it's one or the other until you follow the case, and then whether you respond to antibiotics or whether it doesn't respond. Bacterial conjunctivitis is usually self-limited. It tends to respond to either chloramphenicol or azithromycin drops. It's usually not severe. It's usually something that, if it's not affecting the cornea, doesn't really worry us much. However, if it's persistent, if it's severe, or if it's in an immunocompromised patient, or if the patient keeps getting bacterial conjunctivitis, then they obviously need to be seen by an ophthalmologist. It may be that the lacrimal duct is obstructed, or it may be that they're immunocompromised and they're more prone, so they may need some swabs and sensitivities. Then there's this one, which is a real emergency. It's the hyperacute bacterial conjunctivitis. It's really quick. It starts, and from the moment it starts until it gets really bad, it's only a few hours. It has a lot of purulent discharge. You see subconjunctival hemorrhages, pain, loss of vision. There is a risk that the cornea melts and perforates within hours. This is called hyperacute bacterial conjunctivitis. Can somebody tell me what's the organism? Anybody in the chat? Ooh, nobody? No, I can't. Okay, I saw one answer that was correct. It's not Pseudomonas. I've seen 2 answers now. Okay, those people who answer correctly are getting house points. This is like in school. House points. I've seen now 3 answers, 4 answers, 4, 5, 6, 7. Good. So several of you have answered. So this is gonorrhea. The gonococcus can really kill the eye like in a few hours. It's really bad, and it needs to be sent to A&E running. And they will not only need treatment for the eyes, they need systemic treatment. So they're also going to need to be seen by an STD specialist, a walk-in clinic. So when we see them at the hospital, we send them to the STD clinic on the same day, and then they get their treatment for gonorrhea, and also they're checked whether they have chlamydia, because they're usually together, and then they get the chlamydia treatment too. So well done to all of those who answered. We're keeping the names of all of those. We'll send you the house points later. So this is an emergency referral. Good. So as we've said, so discharge, purulent discharge, infection, so it could be conjunctivitis that we've checked, or it could be a microbial keratitis. It could be bacterial, it could be fungal. Many times it's very difficult to tell whether it's bacterial or fungal the first time you see the patient. Both of them have, you need to think of them if there's a contact lens history, use of contact lenses, or trauma. In the fungus cases, the steroid use, so if they are on long-term steroids, they are at a higher risk of developing a fungal infection, sometimes by just a candida, which is usually not very aggressive, but it grows very slowly. So if it's a very chronic progression in a patient with ocular surface issues and long-term use of steroids, candida has to come to mind. But many times, as I say, it's very difficult to tell whether it's bacterial or fungal, or sometimes, especially in contact lenses, sometimes you can have both at the same time. And they respond initially to antibiotics, and then they get worse. And you need to think then that it's a fungus also, not only the bacteria. And going back to these few points that really need to make you think, oh, this could be worrying. This is what the bacterial or fungal keratitis cause. If there's visual loss, if there's pain, purulent discharge, lasts too long, or is a chronic progression, if there's trauma or surgery, or the contact lens has been involved, and obviously if there's a corneal infiltrate, then you need to tell them to go to A&E. And there is obviously exceptions to everything, especially in medicine. So we've said discharge, purulent discharge, infection, but there are also infectious keratitis that do not cause discharge. And in this case, in this specific case, well done. You're all answering even before I ask you. That's good. So this is HSV. So no discharge, and usually not significant pain, but some discomfort, loss of vision, and you have this typical dendrite. In these cases, we treat them with topical antivirals. Sometimes, as you can see in the picture in the lower left, if the stroma is involved, we're not going to only use antivirals, but also steroids. But the steroids need to be very carefully administered, because if they are given without cover of antivirals, you can end up with a geographic ulcer, which is the one at the bottom right, where the virus just spreads from a small dendritic ulcer into a massive geographic ulcer. So steroids really need to be administered very carefully, and always under the supervision of a consultant, of a doctor, if the patient has previous history of herpetic keratitis. And then there's this next one, another herpes that causes keratitis, that can cause uveitis. Well done. And that turns up in your practice with all these vesicles. Well done. Well done. I'm so happy that you're all interactive. It's making it so much easier for me to know whether you're following or not. Well done. Herpes zoster. And I'm really happy that most of you use the right medical word for it, which is zoster, ophthalmic zoster. Some of you actually answered ophthalmic zoster. So it's shingles for the patients, but if you refer the patient to an ophthalmologist, then it's always nice that you say, and somebody has answered already my next question. Is like, if you see this patient coming into your clinic, what is the sign that will make you worry that that zoster is going to affect the cornea and the eye? And many of you have already answered. Well done. It's Hutchinson sign, which means that the little tip of the nose is affected. That means that the nerve that can go also in the eye can be affected and can cause issues. So if you see a patient like this, you need to tell, I'm with the red eye, you need to tell them to go to A&E. The zoster treatment is better if it's given, so it acts, the prognosis is better, also including the post zoster pain that, as you know, can be very disabling, it's much better the prognosis if we start the antivirals at a high dose, orally, at a high dose, from the moment it starts. So if you see one patient, tell them to go straight away. The sooner they start the treatment, the better the prognosis later on. And then this is not for house point. This is for start of the day. Start of the day is 10 house points, my daughter tells me at school. So this is for start of the day. If somebody answers me, what you need to think of if a patient comes, they tell you they've been wearing contact lenses, they're well done. Rabia gets the start of the day. So the epithelium is, usually the signs are not as bad at the beginning compared to the pain that the patient describes. And there's usually no discharge. Those are the exemptions to the rules of discharge that I explained earlier. So lots of pain in an eye that's a little bit red, but not massively red, with just the epithelium a little bit kind of dirty, not the nicest epithelium, but with not much else there. If a patient wears contact lenses, and especially if they shower or swim in their contact lenses, you really need to think of amoeba. And especially, and now this is the next question, who can tell me the picture in the middle, if you see that, it really is Acanthamoeba. What is the name of that infiltrate? The picture in the middle, this picture here, I don't know whether you can see my... Okay, no, the ring infiltrate is at the bottom. Perineural, well done. Perineural, well done, Caroline. There was another one before that said perineural too. So perineural keratitis is pathognomonic of Acanthamoeba. Means that if you see that, you really need to think it's amoeba, and you need to send them to an A&E. So hopefully we treat these patients, if we receive these patients and we diagnose them early, we can treat them when the disease is only in the epithelium, as you can see in the top images, and has not just reached the stage of the stroma where they create this ring infiltrate. Ring infiltrate is a bad sign of keratitis. If you see these, you need to send them quickly, but it's usually a bad prognosis. Acanthamoeba is a very nasty bug, as you know. So the sooner we treat it, especially when it's just epithelium, we're going to remove the epithelium to send it to microbiology. Just removing the epithelium is not only diagnostic, but it also helps decrease the amount of cysts that are there. And then many of them can respond well if we start the treatment early and it's only epithelial. They should not use steroids. They should not use steroids. We need to wait at least 3 to 4 weeks or as long as possible before we start steroids. Using steroids in Acanthamoeba patients, because they haven't received the right diagnosis to start with, and they've been diagnosed with sometimes herpetic keratitis, then they will make the prognosis. It will make their prognosis worse. So really good. You're all. I don't know why I'm giving this talk. You know everything already. So next one is the discharge. So type of discharge. If the patient says, no, it's not sticky, it's not green, yellow, it's more like mucus, like these fibers that come out of my eye, and it's very itchy. Well done, Nicola. Well done, Claudine, Molly, Dina, Nita. Well, I can't read, you are all well done. So it's allergic conjunctivitis. The main thing, if it's itchy, it's allergic. If it's burning, stinging, is more dry eye blepharitis. If it's itchy, there is a component of allergy. So there are different types of allergy that may just come up into your practice. So acute chemosis. So a patient comes, they say, I took my kid to the playground or to the park, and suddenly I started feeling really itchy, and they come really scared because their conjunctiva is so swollen. That is actually usually not a severe thing. It's an acute chemosis that usually goes very quickly. It's usually something that's gotten from the plants into their eye. If they put something cold, many times it goes away on its own. But if it doesn't, then they need to go to A&E. We'll give them some steroids. That's usually a one-off. That's it. Contact dermatitis. That's also allergic. And if it affects the eyelids, the patient may come saying, oh, my eye is red, but then you see that it's not really the eye inside, but it's the skin around their eye that have this look of an eczema. It's red like in the picture. And then you need to ask, it's usually contact dermatitis, so from some either product that they've been using, so look at their hands, see whether their hands have the same reaction, or sometimes the hand doesn't have the reaction because they use gloves if it's a cleaning product. Sometimes it's, so ask them if they've changed their cleaning products or if they've been in touch with something, or if it's a new cream that they've used, or sometimes nail polish can sometimes cause allergy when they touch the skin, or even hair dye can also cause allergies around the eyes. And that will need to be obviously decide what's causing the allergy and stop using that. Sometimes it's the dermatologist who need to do those things. And then there is the seasonal and perennial conjunctivitis. So those patients who have itchy and discharge throughout the year in the perennial conjunctivitis, or only during the hay fever season. And in these ones, the most important thing is avoid rubbing. The best thing you can tell them is to use lubricating tears that are cold from the fridge, because the temperature, the coldness, or some cold eye masks can really help with the itchiness. They can buy over-the-counter anti-allergic drops, which unfortunately there's only the sodium chromoglicate, which needs to be applied 4 times a day. I don't understand why in England the opatanol, the olopatadine, or the ketotifen are not available over the counter. In other countries in the EU they are, because they do not have side effects, and it would allow the patients to get their allergy under control without having to go to the doctor. But in any case, it's both are the ones that we use nowadays, because they're better than the sodium chromoglicate, because it's not just an antihistamine, but they also stabilize the mast cells. So they will control the allergy in the long term. So if you see a patient using opatanol or ketotifen, and they're only using it like a once off, encourage them, and they're complaining of itchiness and redness eyes, encourage them to use it regularly, twice a day, for as long as the hay fever season lasts, because it's not just for the moment they have itchy eyes, but also to control the allergy in the long term. And you don't need to apply them every 12 hours. So we say twice a day, but what I explain to the patients is once in the morning, and then once in the afternoon, evening, when you notice that the eyes become itchy again, before you start rubbing your eyes, you apply another one. Because usually at night time, then they sleep and a bit better. If it doesn't respond only to antihistamine, so to these two, they may need a course of steroids, which is usually then the ophthalmologist who needs to give them. And then there are 2 other types of allergic conjunctivitis you need to know, which can be very severe. One is the vernal keratoconjunctivitis. That, as you know, it affects children. There's usually a history of eczema or asthma. And it produces this limbitis. So this, I'm not gonna say the word. Does somebody know the name of these dots on the limbus and the lower lid? Transverse dots. Well done, well done. You're all getting house points. Purvi will need to send them later. So the transverse dots are very typical of vernal. They indicate allergy. Sometimes they get just limbitis all around the limbus. You get this cobblestone papillae that I've seen some of you mention too, from this picture at the top right. And they can get some ulcers in the cornea, which are called shield ulcer. Well done, Chris. Cian, Chris beat you to it for 1 second. So the shield ulcers, those are usually covered in some deposits of that do not allow the ulcer to heal. So no matter how well they do the steroids, no matter how well they do the cyclosporin drops, no matter how well they do the anti-allergic drops, they do not heal. And that is because the shield ulcer needs to be scraped. So that deposit that is growing, or that grows on the ulcer, needs to be properly scraped with a needle. Once it's off, then the ulcer will heal very quickly. Sometimes if they're very small, these kids, that needs to be done under sedation. Sometimes if they're a bit older, like teenagers, you can do it on the slit lamp. And then some of these kids grow out of the vernal conjunctivitis, but some of them don't. Some of them then go on being adults with eczema, asthma, and this atopic keratoconjunctivitis. So basically eczema and the eczema around the eyes. And atopic keratoconjunctivitis can be a very severe disease for the ocular surface. It can cause scarring, it can cause corneal vascularization. Because of rubbing, many of them develop keratoconus, and they develop cataracts associated with the inflammation of the allergy, and they are also more at a risk of developing bilateral herpetic keratitis. When you see a patient with herpetic keratitis and they usually only have it in one eye, it's extremely rare to have herpetic keratitis in both eyes. So if you see a patient like that, you need to ask them whether their immune system is okay. They may need some blood tests from the GP. But if they're atopic, if they have atopic keratoconjunctivitis, their immune system is not working properly, and that's why they get herpes in both eyes. And in these cases, a few things that I thought you would find interesting or useful about the atopic keratoconjunctivitis, which are the topical treatment is with antihistamines, like we've said before, and mast cell stabilizers, which are the olopatadine and the ketotifen. The olopatadine is not preservative free. So in these patients, when I'm treating them, I tend to prescribe ketotifen, which comes in unidose. The other one that can be used also is the catachrome, which is also preservative free, but this is sodium chromoglicate, so it's not as useful as the dual antihistamine and mast cell stabilizers. So if the patients can get ketotifen, that's ideal. Be aware that many of these patients are allergic to lanolin in the ophthalmic ointment. So there used to be this ointment Lacrylube, which used to have lanolin. We used to avoid it. Nowadays, thankfully, there are a lot of ointments that are really useful and do not have lanolin. But some patients they may have it on the skin. So if they're asked, if they mention the skin, just mention to avoid lanolin on the creams. They usually become dependent on steroids, and they all need either cyclosporine or tacrolimus. Tacrolimus is extremely useful for the eczema around the lids, extremely useful. And even if it's not licensed to be applied in the conjunctiva, inside the eye, it's used off-label many times. So many times we tell them, well, just let a little bit inside the eye, and that will also help, even if we cannot really prescribe it like that. If a patient comes to you, as you know, the steroids can cause a steroid response and with a high pressure, and you'll be checking the pressure from time to time for these patients. Be aware that even if the patient is not using drops of steroids, they may be using, without any control, they may be using steroidal creams applied to the face. And in those cases, they can also increase the pressure in the eye, even if they're just creams on the skin. So be aware, if you ask them and they are using those, just pay a bit more attention to the pressure in the eye. Okay, so we're advancing well. We're reaching almost the end. I don't know what time are we doing. Okay, perfect timing. So last part of the tree, if the patient say the pain is moderate to severe, there's visual loss, but there's usually no discharge in the eye. And we're going to go picture by picture. So the first picture here with the arrow, and the arrow gives you the answer. Well done. Iris Bombay, well done. And what does that cause? What is the acute problem that patient has? IOP, well done. Angle closure, well done. I see most of you, so it's an angle closure glaucoma. The patient, the degree of pain is variable. Sometimes it's a throbbing pain that they can't tolerate. Some others don't have such high pressure, but usually they see, what is it that they see around the lights that they really need to make you think? Halos, well done. Halos around the lights, colorful halos around the lights, and then you check the pressure is extremely high. Usually you need to send them running to A&E so that the pressure gets under control before they lose their vision. Next picture, down left lower lid, lower on the screen. Scleritis, well done. Scleritis. So the patient will notice that the patient will tell you that the pain is severe, and when the color of the eyes, and sometimes it's better to see the color of the sclera outside the slit lamp, so you make them look down and you elevate their lids like that. They may not let you do that much because they're very tender to touch, but when you see them, you'll see this bluish color, and that's scleritis. Again, needs to be sent to A&E. We're not gonna, I think this picture in the middle, you may not see it very well, but the next one on the right, uveitis, well done. Because what is it that you're seeing in the cornea? You're seeing deposits. How do you call those deposits? KPs, well done. So you're seeing endothelial, keratic precipitates that we call KPs. So those indicate that there's an inflammation inside the eye, and the reason for the inflammation can be different. So you need to send them to A&E, and they'll do the treatment and the diagnosis. I put the picture in the middle, but you cannot really see it. So there's some situations where you have a keratitis that is not infectious, but you have an infiltrate, for example, marginal keratitis, or some others like peripheral ulcerative keratitis, PUS. So some of those situations can be quite mild, some of them can be severe and can lead to corneal perforations. So if you see a patient with pain, with loss of vision, with a red eye, with an infiltrate in the cornea, the discharge, as we said before, will give you an idea of whether that's infectious or not. So if there's discharge, it will most likely be infections. If there's no discharge, it may be just autoimmune and inflammatory. But in any case, it needs to be seen by the corneal specialist. So you send them to an A&E. And we're almost done, but I thought, so we're done with the differential tree, but I thought there would be a couple of things that would be useful for you to hear, since we're talking about what to send to the emergency room or not. One of them is the orbital cellulitis, and the other one is the endophthalmitis. So orbital cellulitis, you need to decide when a patient comes with an inflammation with the skin around the eye, the skin in the lids swollen and hot and inflamed, whether it's just a preseptal cellulitis or whether it's an orbital cellulitis. A preseptal cellulitis is not an emergency. It means that there is infection or inflammation in the skin only, but anterior to the tarsus, and it's not going to go in the orbit. It's not going to affect the eye. So what you see is that it's confined to the lids. If you open the eyes move in all directions without pain, and the eye itself is normal. So the eye is white, the vision is normal, the conjunctiva is not inflamed. And it's usually either a sty or insect bite or a wound that has got infected. If it's a sty, usually just antibiotics are enough, but if there's a possibility of the skin being infected from after a scratch, for example, they may need oral antibiotics. It's different if it's an orbital cellulitis. So the orbital cellulitis comes from behind the eye, from the orbit, usually the paranasal sinuses. So you can see here in the image how this sinus on the right is completely filled with inflammation, and it's pushing the orbit, it's filling up the orbit with inflammatory content, and it's pushing the eye out. So the eye is proptotic. It doesn't move well, so when you try to ask the patient to move towards one side, they cannot do it fully, and also it hurts when they try to do it. The conjunctiva is all inflamed. It may even, depends on the degree, but there may even be a loss of vision on RAPD. That means that it's very advanced. And in these cases, you need to send them straight away to A&E, and they need to get IV antibiotics. The other emergency is the endophthalmitis, as you know. So this is an infection that involves not only the anterior chamber but also the vitreous, and it usually happens after either trauma that perforates, so penetrating injury, or ocular surgery, very typical after cataract. Well, not typical, so it almost never happens, but usually it's cataract surgery. It can also be after corneal grafts, although it's really rare, or after glaucoma surgeries. But it involves painful, severe loss of vision. You see hypopyon, and also when we try to see the back of the eye, you can't see anything. The vitreous is all inflamed, and we see that on a scan. We see that the vitreous is all full of inflammation. it can be this other types of endophthalmitis which are not after ocular surgery or trauma, which are the endogenous ones, which are the ones that the patient gets the infection from inside, because they have sepsis, because they have something that's infected, and then the infection has gone on the bloodstream and has reached the eye. However, it is unusual that you see those patients in your practice because they feel unwell themselves. But you obviously need to think a patient who comes into your practice, oh, my eyes are a bit red, I've had cataract surgery just 2 days ago, I don't know whether I need to go to any, and you see that there's a hypopyon, you need to send them straight away. We do take samples. The protocol now is to always take samples from the vitreous before we inject antibiotics so that we can get sensitivities. And this is more or less, I mean, this subject could be, we could talk forever and look at many other little different conditions that can affect the eye. But I think I've tried to make it as practical as possible so that if you keep in mind these 3 questions that I've told you, whether it's painful or the type of discomfort the patient describes, if there's discharge and what type of discharge there is, and there is loss of vision and what type of loss of vision, if it's just fluctuation throughout the day or if it's a constant loss of vision, a significant loss of vision, it will allow you quite a lot to decide whether the patient needs to be sent and seen to A&E and be seen by an ophthalmologist, or whether it's something that you can advise them on locally. Thank you. Oh, and then these last few things, so just remember, we've mentioned these a few times. So if there are these worrying signs, contact lens, purulent discharge, the trauma, the surgery, then you will be thinking this may be worrying and I should send it. Thank you.
Laura, thank you so much. That was absolutely fantastic. I thoroughly enjoyed it, and I hope everyone else did too. I'm sure they did. That was interaction at its best. Fantastic. We do have some questions, actually. I'm sure more are going to come flooding in, so I'm going to start with a few. We had a couple of questions about, you mentioned steroids, antibiotics. What do you do for pregnant women? For example, we're talking about blepharitis. You mentioned antibiotics. Do you give doxy or linocycline, azithromycin?
No. So doxycycline, when I prescribe doxycycline or linocycline, I always ask them whether they are pregnant, and if they say no, but they are at a age, or I always tell every woman, even if, at this time you never know, so any woman, I tell them not to get pregnant, apart from also, and I don't know whether you know that, but it can give a bit of skin sensitivity with the sun. So I always tell them to avoid sun exposure. And if this is a question that many times comes, so we give, the doxycycline is not a course of 1 or 2 weeks. This is a course of 6 weeks, or sometimes 3 months, or sometimes even long term. So they say, what happens if I go on holidays with a sun exposure? I tell them to stop them before, usually a week before or so, and then you can restart when you come back. It's not a problem to stop and restart. This is not like an antibiotic that you get for an infection of your tonsils that you need to do the 10 days. This is something for the skin. So and for pregnant women, no, we don't use doxys. For pregnant women, we try to avoid everything. Steroids are safe to use. So if they need steroids, if there's something inflammatory in the eye, steroids are easier.
Interesting. You mentioned the photosensitivity. When we do IPL in clinic, if they're taking doxy or linocycline, I ask them to stop. I said we have 2 options. We either continue the doxy and linocycline and see if that helps, or if you want to go down the IPL route, you have to stop because of the photosensitivity. So that's
good point. Yeah,
it's very interesting. We had a question about, you mentioned the episcleritis. If you have a number of episodes that we refer, well, who do we refer to? Do we refer to an ophthalmologist? Do we refer to GP? And what bloods do we ask for?
Yeah, so the GP ophthalmologist question is difficult because it depends on each GP. Some GPs know more about eyes, although I must say the GPs, they unfortunately don't get much training in eyes, so they're usually a bit lost as to what to order, so they'll send them to us, and you send them to in our hospital, at least at Morphils, we send them to the uveitis department. Sometimes we see them a few of them in external, so usually you ask for all the autoimmune screening, so rheumatoid, that can cause episcleritis, HLA-B27, and also you ask, and the other autoimmune autoantibodies. And also you ask whether they have gout. So you check the levels of that in the because that can cause recurrent episcleritis.
Oh, interesting.
Uric acid on the serum.
A question about the pseudomembrane that you mentioned. You mentioned that we have to refer ones that are very severe. What do we class as very severe?
If you see pseudomembranes, they need to be seen.
Okay.
If it's just follicles, petechia, discharge, you can probably say, well, see how you do, and then. But if the eye then starts if they get worse and the eye starts developing the pseudomembranes need to be clean. So, and usually when there's pseudomembranes, we'll probably start also some steroids to avoid the scarring. So that's probably going to need to be done under some supervision.
A question on acute chemosis in allergic conjunctivitis. You did mention that you can use antihistamines. You mentioned you can use steroids, sorry. Could you also use antihistamines orally with eye drops?
Yeah, I mean, the acute chemosis usually goes away quite quickly. So if they have antihistamines, either in drops or orally, and they put some cold thing and it goes away, then that's it. If it's a bit more persistent, then the steroids obviously makes the inflammation go away quicker.
Thanks, Lara. Moving on a little bit, actually, what do you do when patients have severe inflammation, for example, uveitis, but they can't take steroids if they have a bad reaction to steroids? What do you do for these patients?
What do you mean with a bad reaction to steroids? So
we've got patients that are allergic to hard steroids. I guess that you don't come across that very often.
No, so steroids do not cause allergy. The steroids is something you produce in your own body. We all produce steroids. It's the natural anti-inflammatory component. So you cannot be allergic to steroids. You could be allergic to the preservatives in the steroids, but then we always give preservative-free steroids when we treat them at the external disease department. Or they could, what people say are allergic or have a bad reaction means that the pressure went up. And then, yes, and then that's a steroid response. That's called a steroid response, and that's the pressure going up because of the steroids. Uveitis need to be treated with anti-inflammatory medication. So sometimes we can give oral steroids. If the pressure goes up but the patient really needs the steroids, then we use pressure controlling drops. And there are, if the uveitis is bad and is recurrent and is long, sometimes we put them on immunosuppressants, on oral immunosuppressants. However, by the uveitis, this is all the uveitis department though. I mean, we share sometimes some patients, but this is not cornea. But yeah, that's what we do. So steroids, if there's inflammation in the eye, they're going to need the steroids. And if they're allergic to preservatives, we remove this preservative. I mean, we tend to remove the preservatives in cornea all the time anyway. Preservatives are bad for the eye. So preservative-free drops always. And then control the pressure if there's a steroid response, if you really need the steroids, and then consider immunosuppressants.
But I've got a question. What if we have a patient in clinic with acute angle closure, but they live miles away from the eye hospital? And let's say we've got prescribing optometrists and this patient presents with incredibly high OP. How do we treat it in clinic before we get them on their way to you?
Yeah, so if it is a real iris bombay with a pupil block and it's a typical hyperopic patient and things, that you can decrease the pupil. So put pilocarpine so that the pupil hopefully breaks the pupil block. However, I would be a bit concerned about doing that unless you're extremely sure that it is iris bombay with a pupil block, because sometimes touching the pupil can make things worse if the reason for the high pressure is another one, like phacomorphic, for example. So basically, I would just give them lots of pressure lowering drops. So whatever you have, that's always going to help. So if you have beta blockers, if you have Trusopt, brinzolamide, anything you have in your practice, you can give to the patient. They can take Diamox. That also helps a lot. So 500 milligrams if the patient is fit and healthy to get them. And then with that, then you start sending them to an A&E. So rather than touching the pupil, I would probably leave that to the ophthalmologist, but just give them anything you have at hand to decrease the pressure,
Perfect, thank you. We do have quite a few questions coming in. I'm conscious of time, so we are going to try and get through just a few more, if that's okay. Some simpler one rather than acute angle closure. A patient with a subconj hemorrhage, do we need to get the blood pressure checked on the same day, or what's your advice for that?
There's no rush really. You ask the patient, do you take blood pressure medications? They say yes. And they say, well, then it's advisable if you have your pressure checked just to make sure that it's within normal limits. Usually you don't see the patient when they have just literally this minute had the hemorrhage. So the pressures may not be high at that moment, and it's not an emergency thing that they need to rush to do it. But just check that it's well controlled. Many times it's not the blood pressure. Many times it's just a cough, for example, or going to the loo and making a bit of effort, or lifting a very heavy, anything that is a Valsalva maneuver that increases the pressure in the top, part of the body, and that bursts that. Sometimes they've rubbed their eye a lot, so it's just some advice. Just make sure that your blood pressure is under control, but it's not an emergency thing.
A couple of questions on allergic conjunctivitis and seasonal. If you're taking systemic antihistamines and your symptoms are not getting better, you can also use topical olopatadine. Just to confirm.
So actually, that's a good point, and I forgot to mention it. I think it was written on the slide, but I forgot to mention it. So oral antihistamines are not very useful for the allergy in the eyes. They're useful for rhinitis, so for the hay fever that affects the nose, or maybe the asthma. But they're not very useful for the eyes. If the patient, they can actually make the eyes feel drier because they have this side effect. There's an anticholinergic effect, it's called, and they make you produce less tears. So if the patient only has allergy in the eyes, or if the patient has allergy in the eyes apart from the rhinitis, they should be using drops. The drops are far more effective for the allergic conjunctivitis than the oral antihistamines.
And you mentioned that they're okay to use that throughout the seasonal period. Is that correct?
Yeah. Sometimes for some patients, they just use it throughout the year. There's not a
problem. I believe that olopatadine in our formulary might say they have to stop after 4 months. Don't quote me on that. But ketotifen, I think you can use throughout the year, but you don't have any limitations on how long.
Well, so the part of the medication that is anti-allergic, antihistamine and mast cell stabilizer, you can use it forever. The problem with opatanol is that it has preservatives. So it's the preservatives that can cause a toxicity. So if you're using something without preservatives, in these cases, you can use them. We've got patients on anti-allergic drops when they are atopic or when they're perennial conjunctivitis throughout the year.
That leads me on nicely to that next question. Somebody's asked, should we generally try to avoid the preserved ocular lubricants?
Yes, that's a massive. Just avoid any preserved drops. Cornea, external disease consultants, we all hate preservatives. It's not a nice. If it's a one-off, if it's a short course, like a couple of weeks, fine. But if the patient is taking drops, if it's drops that are applied more than 4 times a day, or if it's drops that are applied for long term, they need to be preservative free.
Perfect. A couple more, and then we'll call it a day.
Yeah.
If you see a patient who is asymptomatic and they have KPs, do you need to refer, or do these KPs linger after an episode?
So it depends. If the eye is completely quiet and they have a history, they know they've had uveitis in the past, and it's been treated and they're monitored, they don't need to be sent. Some of these KPs are old. If you see that there's no cells moving around in the AC, then usually they not need to be sent. If they do have significant number of cells in the AC, or if they don't know they've ever had a uveitis, then they haven't never been treated, even if there are not many cells, but you see KPs and the patient is like, no, I've never had any inflammation, they need to be seen because they need to know why that's happened.
Perfect, thank you. Moving on to viral conjunctivitis. Persistent infiltrates, do we need to treat them with steroids? Does it speed up the resolution, or do we leave them? Does the age make a difference of the patient?
The infiltrates after the noviral conjunctivitis, they're quite difficult to get rid of completely. Many patients will have infiltrates in the cornea still months or years after the episode. The question is, are they affecting the vision? If they're not affecting the vision and they're quiet, so when you put the fluorescein, the pattern is completely smooth, they don't stain, means that they're quiet, they're not affecting the vision, the patient is 6'5", we don't need to do anything about those infiltrates. We discharge the patients. If they're active meaning that the patient's vision is affected and they are staining, so they're a bit raised on the surface, then we treat them, but usually they recur after we do a course of steroids. You stop the steroids, even if you taper them down, most of the times they recur, many times they recur. So the best thing is to use a cyclosporine. Drops of cyclosporine help a lot. So if you do one course to give it a try and they respond, but they recur afterwards, I immediately put them on Ikervis. So
interesting, because patients getting hold of Ikervis, if we ask them to get them from the GP, it's really difficult, especially in the NHS, to get these GPs to prescribe Ikervis.
No, the GPs can't prescribe. The GPs can't prescribe Ikervis, so they can continue a prescription that an ophthalmologist has prescribed, but they can't do the first prescription.
Right. Okay. Yeah. I am going to start a poll actually, Laura, but I know it's 7 o'clock, so I'm going to end it. If anyone does have any questions that you really would Lara to answer, please do email them across to me, and I will send them, and she can spend her day answering the questions. Before I do launch the poll, just a quick answers on the chat. I mean, everyone found this very interesting. Do we need a round 2 of red eye from Lara? Would that be useful if we had a follow-up webinar on this with maybe some more conditions that, Lara, you mentioned that you haven't talked about on this talk? Yes, I think that will be a resounding yes. I am going to launch the poll. If everyone could just take their time to answer the questions for the poll, please. It's something that we have to do, and also useful for us to know that we're going on the right lanes in terms of these webinars. Lara, it has been absolutely fantastic. I have to say, it's one of the ones I've enjoyed the most. You know, no disrespect to the other lectures that have been fantastic, but it really interactive.
Okay. It's all about the house points. That really gets it going.
It does. I'm just going to wait for a few more people to just respond to
I'm
this
just going
poll.
through the chat. It's good just to get some feedback.
Right. Oh, there you go. I think it's just taking a little while to upload. Perfect. I am going to end it here now. Everybody, thank you so much for joining us this evening. Lara, again, thank you so much. It was a fantastic webinar. Any final words before I end?
No, enjoy your evening.
Thank you very much. Goodbye, everyone.
Bye-bye.